Sorry about that, we should get this going soon. Anyway, I might as well start sort of give you a little bit of a background on what this is all about. So I was asked to talk about ARDS, what have we learned over the last 50 years. So first of all, I want to say that this is not going to be a state-of-the-art talk. I don't have time in 20 minutes to tell you everything about ARDS. I decided to focus on some areas that I have an interest, that I think there's actually been important changes over time in treatment, and they largely deal with mechanical ventilation, our concept of ventilator-induced lung injury. I think that those are going to be the most important. I will mention a couple of the others, but that's really what the focus is going to be, if we can get this going. It'll be much easier to get this talk with slides. Let's just see. So I know you're going over that. Conflict of interest is really not relevant for this talk. And as I said, this is what I'm going to not cover and what I'm going to cover. And I'm going to talk about a little bit about the definition, which I mentioned earlier today, biology, physiology, and long-term outcomes. So of course, you know, this all starts with this publication in The Lancet by Ashbaum and colleagues on ARDS. As many of you know, this article was originally turned down by the New England Journal of Medicine, which is interesting because it's one of the most highly cited articles. So in that article, basically, it defined ARDS as a clinical pattern of severe dyspnea with cyanosis. The key was that it was cyanosis refractory to oxygen therapy. Patients had decreased compliance and alveolar infiltrates. There were a number of other definitions, probably 10 or 12 or 14 definitions over the years. The Murray Lung Injury Score was pretty well accepted and used for a few years, and actually I liked it in many ways. First of all, it was quantitative, and it dealt with the major factors associated with ARDS. The American European definition in 1992 was, again, I think the most widely used for many years. And then, as you know, in 2012, the Berlin definition came out, and it was not much different than the American European Consensus Conference. One thing it did do, I think, a little bit useful, was it defined hypoxemia, defined severity of ARDS as mild, moderate, or severe based on the oxygenation criteria. And the idea here was that these were associated with mortality. Patients were more likely to die with low PF ratios, not really surprising. But this has been used since 2012, and I think pretty widely accepted. And then last year, a new global definition of ARDS was published, and this dealt with, it made a few modifications. Essentially, for intubated patients, it remains essentially the same as the Berlin definition. But it added a type of ARDS, patients on high-flow nasal oxygen, non-intubated patients. And I think this was a good idea in the sense that these patients were, you know, especially during COVID, a lot of patients were being treated with high flow. And you can say, well, if the patient was treated with high flow or invasively ventilated, they still have the same lung disease, why aren't they called ARDS? So that was added. And then for resource, locations didn't have great resources, the suggestion was also to add, instead of using arterial PO2, PF ratio, to use SF ratio, oxygen saturation, and to use ultrasound as well to make the diagnosis. So I think the important things here are that for most intubated patients, the definition will be the same. For patients with non-intubated ARDS, there's a different category, and I think it's important not to combine these patients together because the mortality, it's going to be difficult to interpret. And then in resource-intense, resource-limited settings, I think it's worthwhile having a separate category. So that's how it's a definition, and this definition is now being used with the definition, with the Berlin definition. In terms of the pathobiology and pharmacotherapy, I'm going to be very quick with this because, as I said, I want to talk about things that have made a difference. So we learned a lot about the pathology or pathobiology of ARDS. We know that it's inflammatory disease, alveolar capillary membranes involved, increased alveolar capillary permeability. You can see a lot of other things on this slide. It's an inflammatory disease, as I said. So we think we know a fair bit about ARDS. Well, if we know enough about ARDS, why is it that if you look at pharmacological therapies, essentially there's no drugs have been shown to be effective other than corticosteroids? So do we really know as much as we think we know about ARDS? And I'd say we probably do not. And we need, going forward, we need a different approach. We need a different definition. The definition is largely physiologic-based, and I think that's why some physiologic interventions have been successful, whether it be prone position or small tidal volumes, because it recruited patients who had a given physiology and a physiological approach. If we're not talking about biology, we need a different approach to the definition. So we definitely need a new definition. This hopefully will help. Carolyn Calfee, and looking at latent class analysis and patients, and actually Pratik Sinha, who's speaking next, has done a lot of this work as well. Basically, the idea was they took patients with ARDS, and it turns out you could group them into two categories, a type 1 and type 2. Type 2 is somewhat hyperinflammatory, so that's the term that's used, although there's some question if that's the right term. And the reason I think this is potentially important is that it looks like with some interventions, if you identify patients with these subphenotypes, you can find previous interventions that look like they would have been considered to be effective. And in this study here, you can see that the hyperinflammatory subphenotype, patients treated with simvastatin, seem to do better than patients who didn't, but in the hypoinflammatory, in the blue, absolutely no difference. So this suggests that if you could identify these patients, now when you do studies, maybe identify them at time 0, and you could then potentially have therapies that have not been effective in the past will now be shown to be effective. But that still has to be proven, and there's some ongoing studies that are doing this proactively. This is a post hoc analysis. So what about the pathophysiology of ARDS? That's where I said I'd spend most of the time. And I think that there's been some big advances, as you'll see. I thought it useful to go back a little bit. And I took this study. I don't think it was ever published as a paper. It was an abstract by Roger Bone in the American Review of Respiratory Disease. This was published 50 years ago. And what they did was a retrospective review of the incidence of barotrauma in 50 patients. This was now in 1975. What did they find? The incidence of barotrauma, and we're talking about severe barotrauma here, was 40%. Just think about your patients in the ARDS now. We don't see it that often, 40%. So they thought, well, let's look at what the mechanism might be. So they looked at the tidal volumes and the PEEPs used in these patients. In the patients who had barotrauma, the mean tidal volume was 22 mils per kilogram, measured body weight. Don't forget, measured body weight, if it was predicted body weight, even be higher. 22, and in the patient without barotrauma, it was very low. Just 17 mils per kilogram. So just think about how treatment has changed in the last 50 years. We use tidal volumes at 1/3 this level. So we were killing patients back then, and I can see Michael Pinsky nodding his head. He was an intern back then, probably. And the idea was get the PCO2 normal. Get that. Doesn't matter what you have to do, what pressures you have to use, get it. So that's been a dramatic change in ARDS over the last number of years. And there's a number of experimental studies looking at this. This is a great study, a classic study by Webb and Tierney. They took rats, ventilated them for an hour, either with a low pressure of 15, peak pressure of 15, or peak pressure of 45 with 0 PEEP. And you can see on the right that you can see on the right here, the lung looks like it's actually a liver after just 1 hour. If they added 10 of PEEP, you can see in the middle, here the lung looked relatively normal. So PEEP was effective in decreasing injury. Another important set of studies by Didier Dreyfus and colleagues showed that it wasn't the pressure at the airway opening that's important, but the lung stretch. Simple experiments. They took rats, put a strap around the chest wall, and then ventilated them with the same pressure. But obviously, if the chest is strapped, the tidal volume isn't very high compared to when the lung is not strapped. And you can see that with the high pressure and high tidal volume, there was an increase in extravascular lung weight. that was quite significant. And with high pressure and low tidal volume, that was not the case. So the critical factor here was lung stretch, not airway pressure. That itself was not surprising. This is a study by Bauhaus, published in 1969 in Nature. And he was not interested in ARDS. He was interested in the physiology of musical instruments. And he showed here, on the x-axis is pressure, on the y-axis is lung volume. And you can see there's three instruments, an oboe, a flute, and a trumpet. And the pressures are shown here as a function of lung volume. So you can see here, let me just get I can't get the pointer to where, oh yeah, here we go. If you look at one here, this is an oboe. Well, number one, you can see there's an oboe. The pressures are around 25 centimeters of water. The lung volume goes from almost TLC to 50% of TLC, and pressure is 25. Look at the trumpet player. The trumpet player is number 3. The pressure is, he blows into the trumpet for 5 seconds. The pressure is 150 centimeters of water. So you think if that was a patient on a ventilator, of course the patient's going to have a barotrauma, they're going to have a pneumothorax on the first breath. And the reason that doesn't happen is because the transpulmonary pressure is not increased. To generate that 150, the respiratory muscles are active, you get a positive pleural pressure, and the transpulmonary pressure is not increased. So it's not the airway pressure that's important, it's the transpulmonary pressure that's important. We showed and developed the concept of adduct trauma with ventilation at low lung volumes can cause lung injury. And this was a simple study, ex vivo lung model in rats, in which we ventilated them from PEEP below the inflection point to PEEP above the inflection point. The two top graphs are PEEP below the inflection point, and you can see after ventilation, the pressure volume curve has shifted down, the lungs have become more stiff, just with a couple of hours of ventilation. Not the case with either PEEP greater than in the inflection point or with control where the lungs just hung there for a couple of hours. So that showed that the ventilation from below to above to recruit and de-recruit the lung could cause lung injury. Important discovery was that of Gattinoni and Picente on the concept of baby lung, the idea being that the lung is affected in such a way that there's a lot of atelectasis and fluid, and only a small part of the lung is available for ventilation. So if you take a normal tidal volume and put it into a small bit of lung, you're going to cause lung injury. So that's the concept of baby lung, I think a very simple concept, but a very important one. And then Keith Hickling in 1990 did a very interesting study. This was, many years ago. And he wanted to see whether a strategy which we would now call lung protective with permissive hypercapnia might improve survival in a patient with ARDS. So he took patients with a lung injury score, the Murray score I mentioned earlier, greater than 2.5, and he ventilated a control group. This was not a randomized trial. He had a historical control group, and he ventilated a group with this lung protective ventilation. The mean PCO2 in the hypercapnic group was 62, and some patients went up to a PCO2 of 129, 130, pretty severe respiratory acidosis. And what he found was the expected mortality based on Apache would have been about 40%. The actual mortality was 16%. So again, without a randomized controlled trial, it's hard to say whether this is real, but I think, again, an important study suggesting that ventilation, which is lung protective, can be beneficial. The interesting part about the high PCO2s was it followed a study by Darioli and Perret that was published in patients with asthmaticus. They had severe asthma, and mortality for patients with static asthmaticus was 30% back in the early 80s to late 70s. And they used controlled hypoventilation and showed the mortality decreased essentially to 0. And again, it's not surprising in terms of the CO2 that people can survive. There's a concept called apneic oxygenation, which you ventilate the patients with oxygen, 100% oxygen, and then you paralyze them, and you put a source of oxygen at the mouth, and over the next half hour to an hour, the PCO2 goes up at about 4 mils per milligram per minute, and the saturation, however, remains relatively normal, above 95%. What Fruman did was did this in patients going to the operating room who had normal lungs, had no major problems, going for routine gallbladder or appendix, and used this apneic oxygenation. After 1 hour, here are the results in 5 patients. If you look at patient 4, the PCO2 after 1 hour was 250 millimeters of mercury. The pH in that patient was 6.72. And apparently, all these patients did fine. There was no major arrhythmias. They woke afterwards. So it showed that permissive hypercapnia was very well tolerated, at least in normal patients. And that led the way for this permissive hypercapnia in terms of lung protection. And we showed in 1997, developed the concept of biotrauma, in which ventilation with different ventilatory strategies, and I won't go into the details, that doesn't matter, was associated with increased in various cytokines. This was lung lavage cytokines. You can see tumor necrosis alpha. There's a break in the axis there, so that group had 0 PEEP and over distension had about a 50-fold increase in TNF alpha. So that's in the lungs. And we showed with Marco Ranieri a randomized trial published in JAMA about 25 years ago that in control patients, plasma levels of cytokines, in this case IL-6, you can see over time, over 3 days, went up in the control group, and in the lung protective strategy, which was a little bit higher PEEP, smaller tidal volumes, went down. Basically just showing that the concepts we developed in the animal models in animals was also true in humans. And a subsequent study in JAMA, we showed that what happens in the lung with a lung protective strategy can affect distal organs. So this was a rabbit study in which we had a lung protective strategy and a strategy which was less lung protective, same mean airway pressure, same arterial pressures, and you see that in the kidney, there was an increase in the apoptotic index in the kidney and in the villi, but not in the crypts of the small intestine, suggesting that what's happening in the lungs is not just limited to the lungs, but can actually have impact in distal organs. And we summarized this in a couple of review articles. One was a hypothesis paper shown on the left in 1998 with Lorraine Tremblay, and on the right was a review article in the New England Journal of Medicine showing that basically mechanical ventilation can cause injury to the lung that can be associated with physiological abnormalities in decreased compliance, but it can also lead to release of mediators in the lung, as I showed you. If those mediators translocate from the lung into the systemic circulation, it can lead to multiple organ dysfunction and eventually death. And this may be the mechanism by which, when patients with ARDS die, usually they die of multiple organ function, not due to multiple organ failure, rather than hypoxia. So based on all of those studies, the ARSNet investigators did a classic study, which you're all familiar with, which showed that a lung protective strategy using 60 ml per kilo versus 12 ml per kilo predicted body weight and limiting plateau pressure to 30 centimeters of water was associated with a 9% absolute reduction in mortality. And one of the interesting things about that study was, people thought, well, why would this be? Well, the oxygenation, in fact, was worse in the low tidal volume group than in the high tidal volume group. So that wasn't the reason for the decrease in mortality, likely related to the cytokines I talked about or other mediators I talked about earlier. So that led to a change in philosophy of mechanical ventilation over the years. If we think about mechanical ventilation from the 1960s to the 1990s, and again, that abstract by Roger Bone, I think, sort of really makes the point. The focus back then was get the blood gases normal. People really weren't even thinking about lung injury per se. They're thinking about hyperoxic lung injury and other things, but they weren't thinking about lung protection. So that was the focus, and if that's the focus, you use high tidal volumes if you have to, use high pressures if you have to, get the blood gases normal. But the concept has changed, the philosophy has changed to clearly focusing on lung protection. What's important is to keep the lung protected. You don't need normal blood gases. Of course, you'd like them as normal as possible, but that's not the real goal. PCO2 doesn't matter that much. Of course, the PO2 matters, but even there's a concept of maybe controlled hypoxemia, a little bit of hypoxemia. And then, some great studies looking at prone position. Claude Guérin published in 2013, clearly a major advance in our treatment of ARDS. Wasn't used as much as it should be, although I think during COVID it was used more and more, and hopefully most of the people in the room are using the prone position for patients with PF less than about 150. High flow with nasal oxygen and acute hypoxemic respiratory failure. Again, the study by Fratt in 2015, you can see high flow nasal oxygen basically preventing intubation and was effective in decreasing mortality. And ECMO for severe ARDS, the study by Alain Combs et al. This, as you can see, the probability by log rank test was 0.07 in the study, not quite the magical 0.05. There was a subsequent, I don't think I have the slide, a subsequent analysis using a Bayesian approach, which suggested that with high likelihood that this was effective. And in fact, the editorial by the editor and by a statistician really made that point that I think now that ECMO for certain criteria that are in this paper makes sense to use for very severe ARDS. The concept of driving pressure also became important. The paper by Marcelo Amato in 2015 published in the New England Journal of Medicine. I'm not going to go over the details, but just to say, turns out that the driving pressure shown on the x-axis here is much more a better predictor of mortality than tidal volume or plateau pressure. You can see here on the bottom there's the tidal volumes of these patients and with the different plateau pressures, with the different driving pressures. And with a driving pressure of 20 to 25, some patients had tidal volumes of only 5.7. That was the interquartile range. So it was really, the important factor here was the driving pressure rather than the tidal volume per se. And Luciano Gattinoni developed the concept of mechanical power as another approach to think about this. I think this is useful. I do think that this has some variables in it that are not particularly relevant, because this takes into account the resistance. If the resistance of the lung goes up, if you use a smaller endotracheal tube, the power is going to go up, but ventilator-induced lung injury is not going to increase. So I think it's really the static part of this that's important, but I think a useful concept to think about. And then in 2017, along with Laurent Pichard and Antonio Picente, we developed the concept of self-inflicted lung injury, suggesting that ventilator-induced lung injury may be the wrong term. It really should be maybe ventilation-induced lung injury. This is the concept, but there was a number of studies dating back to 1988, an animal model, which showed that an animal that's promoted to give an increased ventilation by acid into the brainstem, that they developed very large tidal volumes and in 24 hours developed what looked like ARDS, or acute lung injury. So over the years as well, there's been better tools for assessing physiology at the bedside. I'm not going to spend much time on this. Electrical impedance tomography has become popular. We still don't know exactly where to use it, although it's taught us a lot about the distribution of ventilation in the lung. It's taught us about pendeluft that occurs in the lung that can itself lead to lung injury. A lot of respiratory things. There's airway opening pressure is important. The RI index to tell you if the patient is recruitable. There's automated ways for the synchrony. These are they've been out for a while, but are just starting to become important. When I say starting to become important, to see if we intervene with any of these, does it actually improve outcome? I don't think we've really shown as yet. The other thing that I think is important over the years is the importance of following patients for long-term outcomes. And Margaret Herridge has done some beautiful work published in the New England Journal looking at 1-year and 5-year outcomes, and basically saying that the impact of having ARDS and being ventilated can last for quite a long time in some patients. And it's not just the patients, this is not related to ARDS per se, but in caregivers of patients, they can have PTSD after a year just by having to take care of sick patients in the ICU. So, in conclusion then, what I've tried to show is we've made some progress in the past 50 years in our understanding and how we treat ARDS. It's interesting that I would say the definition, we haven't made any progress. You know, the definition basically sucks, although somewhat useful for looking at ventilatory or physiologic interventions. We really need a better way of defining ARDS, and maybe not ARDS per se, but defining treatable traits that we can treat in a specific way. So maybe in 10 or 15 years, we're not even going to have the term ARDS. Maybe 20 years, the term ARDS, it'll be, this one has acute respiratory failure with a high IL-6, and that's what you treat. I think that's coming. I think we've had an increased understanding of the pathophysiology, and especially in terms of the pathophysiology of ventilator-induced lung injury. I think we've made a fair bit of progress there. I guess the evidence for that is we have therapies now that decrease mortality if you aim to change that. But pharmacological therapies are clearly very disappointing to date. There's lots of hypotheses and lots of approaches. Hopefully those will change. I think there's going to be many changes in the future. I talked about this briefly this morning. I think that it's going to be greatly impacted by artificial intelligence. There's going to be closed-loop ventilation that uses artificial intelligence. Maybe the machine learning is going to tell us what our saturation target should be. It'll tell us a lot more going forward. It's really quite dramatic what's happening with AI in the next couple of years. So thank you very much, and I'd be happy to take any questions, I think, after the next speaker.
Thank you very much, Professor Arthur. It's my pleasure now to present Dr. Pratik Sinha, who is a dual-trained physician, scientist in intensive care and emergency medicine. He's currently practicing in the ICU of Washington University. He leads the cutting-edge research program that integrates multidimensional data with clinical insights to unravel the heterogeneity of critical care syndromes such as ARDS and sepsis. He's going to present to us about ventilatory ratio, whether should it be the standard care in invasive mechanical ventilation. Please.
Great, thank you. It's great to be here. What a wonderful conference, and I'm really enjoying my time in Kuwait, and I thank everybody for all the hospitality. Okay, so I'm going to talk to you today about ventilatory ratio and whether or not ventilatory ratio should be standard of care in invasively mechanically ventilated patients. Although that's a question I'm going to leave right to the end, and maybe you guys can make your own mind up. Okay, these are my disclosures. None of them are relevant to the talk I'm about to give you. And just before I go on, I really want to acknowledge the contributions of my mentor, Neil Soni, who helped develop ventilatory ratio, and we worked together on it. Neil has now retired, but continues to break new ground in science. Okay, so I'm going to talk to you about what the objectives of this talk are. I'm going to start by bad-mouthing the PaO2 FiO2 ratio. I'm going to tell you why it's useless. And then I'm going to make some references about Pink Floyd, and also I'm going to show you some pictures of the world's largest Douglas bag. I'm going to show you some equations and talk about ventilatory ratio and tell you exactly what it is. I'm going to show you lots and lots of data because I run a data science lab and I have plenty of it to show you. And there's a lot in the literature. And then hopefully I'll dodge some questions that you have for me at the end. Okay, so let's talk about the definition. I think Professor Slutsky did an amazing job to highlight the limitations of what the Berlin definition is, and arguably the global definition even expands the heterogeneity. But closer inspection shows that in terms of measured variables, measured physiological variables, we categorize patients or diagnose them with ARDS using only the PaO2-FiO2 ratio. You can say that the chest X-ray is a physiological measure, but really it's just a snapshot. So the only thing we really use is the level of oxygenation. Now, this new definition, the new definition has arguably expanded the heterogeneity more, but the problem with emphasizing just the PaO2-FiO2 ratio is that we know it's problematic. We know that its clinical utility is uncertain. It's highly dependent on FiO2. For example, in this study, these investigators, just by increasing the FiO2 from 0.5 to 1, found that the categories of patients, whether or not they had ARDS at all, changed. Similarly, Jesus Villar has done plenty of work showing that the categorization of the ARDS definition is highly subject to how we change the PEEP. In these set of studies, depending on whether you change the FiO2 and PEEP, patients change from a PF ratio of 200 to 300 to not having ARDS altogether. Again, suggesting there is instability of the PaO2-FiO2 ratio contingent on whether you change the PEEP or the FiO2 ratio. And there is also a biological disconnect with the definition. It tells us almost nothing about etiology. And as, again, Professor Slutsky highlighted, that ARDS is a highly complex, fluid, and variable biological state. And I'm saying this, it's tongue-in-cheek, but really, the PF ratio, we can all deal with problems of oxygenation. And we know what the interventions are and what the end game looks like. And arguably, there aren't that many patients that die from failure of oxygenation. One of the most important things when I think about managing my patients is compliance. Yet the definition lacks any metric of compliance. And in addition to that, I will argue with you that we think dead space is a really important factor. So this is the said Pink Floyd reference. Now, the side of the moon that we can see is oxygenation. And I'm arguing here the side that we tend to ignore and forget about is ventilation. And there are many reasons for that. One of the principal reasons is that it's kind of technically challenging to monitor ventilation. And so to briefly, I'm sure most of you know this already as practicing critical care clinicians, but this is the classic Riley model of dead space. Over here, what you have is no, excuse me, you have no fresh gas going into the alveoli, but you've got perfusion that represents shunt. In the middle over here, you see we have a normally perfused and normally ventilated alveolar unit, where the VQ matching is ideal, followed by what you see to your right is dead space, whereby there is no perfusion, but you're getting fresh gas going into the alveolus, and that portion of gas is not participating in gas exchange. So the way we estimate physiological dead space, or VDVT, is to use the Bohr-Enghoff dead space. Here, arterial PCO2 represents a surrogate for alveolar PCO2, which is, again, technically difficult to measure. The PeCO2 represents the mixed expired CO2, and of course you divide that by the arterial PCO2. So that's Bohr-Enghoff's dead space equation, and that's how we estimate dead space. In this landmark study by Nuckton and colleagues in 2002 in the New England Journal, they showed that as you increase dead space fraction, these are sort of quintiles of dead space on the x-axis, so as you can see it going up. As your dead space fraction goes up, your mortality on the y-axis increases. And this was true after they adjusted for multiple factors of disease severity. Since then, multiple studies have subsequently shown that dead space is an important independent predictor of outcome. Now, I've shown you all this information, yet proceeding from there, there's some studies that have also indicated that besides prognostication, there may be some other utility for dead space. This includes PEEP titration and success of some interventions such as prone positioning and weaning. So all of this builds a picture that dead space ventilation may be an important marker to measure in our patients. The reason why we don't do it is because it's quite challenging. Traditionally, this is how it was measured. This chap has a Douglas bag on his back, and it's collecting the expired gas, whereby you collect the expired gas, and I did this for my PhD, where I took a big sort of bag, attached it to the back of the ventilator, collected the expired gas, and measured the CO2 concentration, and you subtract that from the alveolar PCO2, divide it by the alveolar PCO2 to estimate dead space fraction. But we have since developed a useful and easier way to do it, and that's using volumetric capnography. Yet, for some reason, volumetric capnography, and some of this is probably due to the fact that these machines tend to be standalone, or if they're integrated into the ventilator, you have to pay additional money for the software to measure volumetric capnography. But volumetric capnography gives you a pretty decent estimate of dead space fraction, but despite being around for now almost 3 decades, it hasn't become the standard of practice. So when we came to thinking about how can we develop an index that does for ventilation what the PF ratio does for oxygenation. So something that's easy, not perfect, but usable at the bedside. And these are the questions that we asked ourselves. And specifically, we wanted to know about invasively mechanically ventilated patients. So this is what ventilatory ratio is. We define ventilatory ratio as your minute ventilation multiplied by your arterial PCO2 divided by a standard for those measures. The standard for those measures were, for arterial PCO2 was 5 kilopascals, and because I did my PhD in the UK, those are the units that we use over there, but subsequently we've translated that to 37.5 millimeters of mercury, and for the ideal minute ventilation for a patient, and we used some standards developed for anesthesia, 100 mils per kilogram of your predicted body weight. And so for a patient that measured 70 kilograms, we would have the measured minute ventilation multiplied by the measured arterial PCO2 divided by 7,000 times 37.5. You will notice that VR is unitless, and a value of approximately 1 represents normal ventilatory efficiency. When we did physiological analysis of VR, we found that VR was influenced predominantly by 2 things. First, the CO2 production. So when CO2 production goes up, which is VCO2, VR would go up. Or dead space. If dead space goes up, VR also goes up. Or if both go up, then VR would go up. So in this paper, which is published in the Blue Journal, we asked the question about what were the physiological correlates of ventilatory ratio in a large cohort of patients who had ARDS and were mechanically ventilated. We tested the hypothesis of VR's association with both dead space as measured using volumetric capnography and the Bohr-Enghoff equation and VCO2. And we did this in multiple cohorts, which included observational cohorts and a subset of clinical randomized controlled trial. So in the observational cohorts, this was 520 patients with ARDS. These were collected between 2010 and 2016. All patients were under mandatory modes of ventilation, and patients had both VDVT and VCO2, so dead space and VCO2, measured at the same time as we procured an arterial blood gas, and we used the corresponding minute ventilation to estimate dead space. And we also looked at some other markers, including VE corrected, which was used during the derivation of the Berlin definition and got rejected because it did not prognosticate patients. So we found that dead space was significantly correlated. You can see physiological dead spaces on the x-axis and ventilatory ratios on the y-axis, that it correlated with dead space. However, it did not correlate with measures of VCO2. Again, we found that dead space was, ventilatory ratio was a significant predictor of outcomes. The odds ratio for mortality with every increasing unit of ventilatory ratio was 2, and this remained so after we adjusted for multiple factors for severity, including Apache score, PEEP levels, and oxygenation index. However, these other indices that I talked about before, these are estimated dead space indices, or VE corrected, were not associated and did not predict outcomes. We used a cutoff of 2 to demarcate groups of high VR versus low VR, so people with significant ventilatory inefficiency, and found that mortality was higher in the high VR group compared to the low VR group, and this was true in a randomized controlled trial too. And it seems that this cutoff of 2, which we just flipped around the median value of the population, seems to have some validity in this study by Sidai and colleagues of 350 patients with ARDS. They too found that at about a range of 2 of VR, there seems to be a point of inflection, as you can see in the graph with the red, red rectangle around it. Now, subsequently, in this study by you and colleagues, they did some analytics and found that a cutoff of 2 was, again, predictive of higher mortality, where they used some statistical analyses and cut point analyses to determine that 1.98 seemed to be a cut point to predict outcomes. So using this cutoff of 2, what I'm trying to show you here is that there is no correlation between VR and PaO2 FiO2 ratio. So on the x-axis, you've got the PF ratio, and on the y-axis, you've got ventilatory ratio. And this makes sense because of what Professor Slutsky showed you before, that you can oxygenate people, but yet their CO2 goes up. Things like jet insufflation is a sort of a neat demonstration that these two measurements are not intimately correlated, unless, of course, they're a shunt, and I'll talk more about that later. Now, this lack of association between ventilatory markers and oxygenation becomes more dramatic if we just look at the most severely ill patients. So these are people with a PF ratio of less than 100, and as you can see, the spread of ventilatory ratio in these patients is much higher. And clearly, those patients who had a VR of greater than 2 had a higher mortality of 51% compared to 34%. So in a meta-analysis by J.S. Simon and colleagues, they looked at whether or not ventilatory ratio predict outcomes, and across multiple studies, they found that VR was associated with outcomes, so suggesting that cumulatively, there's a growing body of evidence that VR is an important prognostic marker in patients with ARDS and acute hypoxic respiratory failure. So to give you an idea, I did my PhD, we published a few studies on this, and generally the uptake of VR was quite low until the first paper that described COVID-19 showed ventilatory ratio as an important marker in these patients. And since then, the amount of data that's coming in the literature has really exploded. There have been multiple studies, over 250 studies that have used ventilatory ratio. Difficult to summarize them all, so I'm just going to show you a few studies of interest. We've shown that VR is higher in patients with severe and critical COVID-19. Most studies have reported its prognostic value, although this isn't ubiquitous. The methods used to calculate VR are variable. It's worth noting that the time that you measure the arterial PCO2 should be closely associated with the minute ventilation that you're recording. And sort of retrospective analyses quite often fail to capture this, so we're not really sure about the validity of the estimates. And so, because of COVID-19 and the subsequent explosion, there's been multiple innovative uses of VR, and I hope to show you these over the next sort of 5 minutes or so. So there's a deluge of data coming towards you. So in this study by Massimo Antonelli's group, they looked at how COVID-19 differed from non-COVID-19 ARDS. And it's worth pointing out my old friend compliance was different between the two, but the only other respiratory variable that was also significantly different was ventilatory ratio. Now, this could be due to increased dead space, of course. It could be due to increased CO2 production, which seems unlikely for various reasons. But also, an interesting factor, as we know with COVID-19 and how people described a lot of embolisms, that shunt might be an important factor. And I talked to you about shunt being important because that's where there starts to be a growing association between ventilation and oxygenation. So the higher your shunt fraction, the more these variables are intimately related. And in this study by Brij Patel and colleagues, they found that PaO2-FiO2 ratio and ventilatory ratio were indeed correlated in patients with severe COVID-19. And now, in this study by Giacomo Grassilli and colleagues, they looked at quantiles of D-dimer using as a surrogate of looking at thromboembolic burden and found that as these quantiles increased, ventilatory ratio also increased in these patients, suggesting that in COVID-19, shunt may be an important contributor to ventilatory ratio. So now I'm going to show you some data about ventilatory ratio. It's a time-varying variable. So how does it behave over time? In this study with Louis Boss and colleagues, we looked at how ventilatory ratio progressed over time. So we did some group-based trajectory analyses and found there were two phenotypes of VR. And there's phenotype A and B. Phenotype B was patients with high VR that kept rising. And what we found was that by all metrics of disease severity, including multi-organ failure, ventilatory ratio in trajectory B, which was the patients who had increasing VR over time, showed that there was greater multi-organ failure and worse outcomes in these patients. Notably, the only other respiratory variable where they found an association with trajectories and outcomes was mechanical power. PF ratio and static compliance were not associated with outcomes in this patient. Now, in this group where Jiang and colleagues did a analysis of 4 ARDS trials, they again found that over time, as you measured VR, it continued to be associated with outcome almost all the way out to day 21 and beyond, suggesting that it might be useful not just at baseline, but also at multiple metrics. And we found the same thing again with the ROSE trial, where patients that had worsening VR had worse outcomes compared to those patients who had improving VR. And so I hope I've convinced you with these multiple studies, both from our group and beyond, that VR has some prognostic value. But arguably what critical care doesn't need is another prognostic indicator. So the question is, how can we start thinking about using this as a tool to start helping clinical decision making? And so in this study, Wang and colleagues looked at how do respiratory parameters change upon prone positioning, and what's its outcome with success of prone positioning. You can see in the gray line here are those patients that have failed, and in the blue line are patients that have successfully been weaned from the ventilator. And you can see that a drop in VR was predictive of whether or not you would succeed in extubation following prone positioning. However, this wasn't true. That relationship wasn't as clear-cut with PaO2-FiO2 ratio, which is the graph on the right. Other investigators have also looked and found that ventilatory ratio is associated with predicting outcomes. And on this chart, you can see on the x-axis is change in ventilatory ratio, and on the y-axis is ICU mortality. And this is in prone positioning. You can see that if you have a change in VR and your VR increases on prone positioning, your outcomes are worse. And if it decreases, your outcomes improve. That relationship is not so obvious among supine patients. And this is probably the largest study of its type. This is almost 1,800 patients, where De Rosa and colleagues looked at COVID-19 and prone positioning, and again found that increasing VR was associated with worse outcomes once you prone patients, suggesting its utility there. I'm finally going to just run you through. This is the REST trial. I'm sure you'll know about it. This tested extracorporeal CO2 removal in patients with acute hypoxic respiratory failure. And this study found that there was no benefit, no mortality benefit with the intervention. However, in a secondary analysis by Dianti and colleagues, they found that as ventilatory ratio increased, you can see in the intervention arm, which is the red arm here, that survival, so on the right of this graph here, you can see survival is lower, survival is improved, mortality is lower in patients with higher VR who were given extracorporeal CO2 removal. Now, you have to take this with a huge grain of salt, huge pinch of salt, because this is a secondary analysis. Nevertheless, I think physiologically, this has some, these findings are quite intuitive. So what are the next steps for ventilatory ratio? Almost all the studies that I've shown you are retrospective analyses, apart from some of the studies, including the ones from Louis Boss and colleagues, where they deliberately measured ventilatory ratio. We need some more prospective data to try and verify whether it is useful for prognosis, but also, are these changes that we're seeing measurable when we deliberately go out and record this information? And then the question is extracorporeal CO2 finished after the REST trial, or are we not selecting the right patients? It seems to me intuitive that if you have failure of CO2 clearance, i.e. your ventilatory ratio is high, that an intervention like this might be useful. Because trying to ventilate patients who are poorly compliant and can't clear the CO2 is problematic, whereas the harm associated with extracorporeal CO2 removal and the intervention associated with it probably negates the benefit in patients who have got normal lung compliance and normal CO2 clearance. Is VR a tool for potentially predicting the need for ECMO after prone positioning? Can we use VR or dead space to optimize ventilator settings? I would argue that even though I'm a proponent of ventilatory ratio, I think the era of using single variables to try and categorize our patients may be over, and that VR on its own may not provide all the information that we need. And really going back to, I'm not quite sure why we got rid of the Murray lung injury score, because it had many of the components that we needed to try and assess our patients. And arguably, VR just adds to that tool. So I will leave you to make the decision of whether or not we should be measuring VR in our ICUs. We measure it in our ICUs, and certainly for some patients, it proves to be useful in terms of developing our algorithms of how we will progress, particularly in patients with severe respiratory failure. So in summary, I'd say VR is a simple index. It correlates with dead space and is associated with outcome. It's affected by dead space, CO2 production, or shunt. I hope I've shown you enough data to convince you that it's mostly dead space, and perhaps in the context of severe COVID, as we knew it, there was the contribution of shunt. It predicts outcomes in multiple cohorts, totaling over 10,000 patients, and it may potentially be useful for decision-making at the bedside, but we need to start developing these algorithms to test prospectively. And it potentially might be used for predictive enrichment in ARDS, and to introduce the idea of treatable traits and physiological treatable traits of how we can do precision trials in mechanically ventilated patients. So with that, I thank you for your attention, and happy to take questions.
Thank you, Dr. Sinha, for this presentation. Is there a question in the room? We can ask question to the, Dr. Slutsky and Dr. Sinha.
I'm going to nominate Professor Slutsky to answer all my questions too.
Hi, this is Dr. Sarah. I'm a critical care and doctor in Kuwait. So we talked about the vent ratio, but the question is like, can we use the vent ratio at the bedside, or we predict in the future to help us guide this manager that's like when to decide about proning or maybe want to initiate ECMO? Because all these studies are amazing, but then when we are at the bedside, should I, is there a prediction toward using the vent ratio rather than PF ratio to help us make decision what to do with our patient, or just merely predictor that they're going to do, these patients, they're going to do worse?
Yeah, thank you. That's an outstanding question. And, I think it sort of speaks to the broader challenges of developing all of these excellent respiratory physiology markers. What we need to do is develop algorithms of how do we operationalize this information that we're getting out of the ventilator, or in this case, ventilatory ratio, to try and help us make clinical decisions. And the argument I would put forward about how we should seek to manage our patients or even do clinical trials is to add layers of sophistication and see what is the information that's coming at us and build algorithms to help that decision making. For example, in a given scenario, say we had a patient and we've proned them, we get all the data back to see what was their data, like PF ratio, ventilatory ratio, mechanical power, before and during prone positioning. And if they haven't shown improvements in some of these elements, for example, if their CO2 clearance hasn't improved, then we need to think about challenging them with a new intervention. And there are trials that are currently happening, like the practical trial in Canada, where they're making interventional decisions based on respiratory features that they are observing at the bedside. So I do think that the future of how we manage patients on the ventilator is contingent, I think, on this multivariate information that we're getting, and to channel people to interventions according to what we observe, rather than using a one-size-fits-all approach to it.
Do you have a specific RCT in mind using ventilatory ratio? Because I really like your ideas, I like the concept, but something specific, how would you actually go ahead and use it?
So for me, I think the most sort of approachable specter would be to try and interrogate extracorporeal CO2 removal. And I would say that patients who on optimal ventilatory support, so what you feel good in terms of minimizing stress and strain, you are not clearing your CO2 and your CO2 is continuing to rise. I think those are the patients that I would consider challenging them with extracorporeal CO2 removal. I think it makes physiological sense, pathophysiological sense to me.
In terms of ACOR, I would suggest we're not ready to do any trials until we have better equipment. It's the complications that are a complication for the studies. I agree with you in terms of picking the right patients, but I think that we're not there yet. The low flow rates, the equipment is not designed and it's problematic.
Yeah, I completely agree with you. I think what was used in REST, the complication profile of it is it's hard to justify. But I don't think it's CO2 removal. I don't think it's that far away. I think we can improve the technology to try and bring it to the bedside in a safer way.
But the best method to calculate ventilator ratio is at the bedside. We've seen that there is an application from the Toronto Ventilator Center. We can use it. Is it the best method to calculate the ventilator ratio?
Yeah, so there are apps now that are developed. There are some ventilators that also have incorporated the equation. It's really quite easy. You take the patient's predicted body weight based on their height, you multiply it by 100, and you multiply it by 37.5 or 40, and then you just take the measured minute ventilation and arterial PCO2. It's quite easy. There are apps available which you can use to try and estimate it.
Tom, is that your... Yes. I have an online calculator. I'll share the link when I give my presentation in a couple of moments. So, and I have a web application. It's an online calculator. The URL is respiratorycalc.com, or rtmaven.com is also the same. It points to the same one. I'll share a link when I give my presentation. There's a number of videos for my talk, and there's a ventilatory ratio calculator that's been there for a couple of years now because I like your work. Thank you.
Thank you. So I have a question for Dr. Slutsky. Again, if you had sort of carte blanche, you were the king of ARDS, how would you seek to redefine it in a way that's that will bring a skeptic like me over and say, you know what, this is something I really need to get stuck into, and it's a problem I can help fix?
You know, if I was a king, you know, I think what we need is a biomarker or physiologic marker or markers that you then can target and actually make a difference. So that's easy to think about conceptually. Hasn't been so easy to actually get those biomarkers in place. But that's what we talked about by having a treatable trait, just having something that you then attack and you treat. It's in the pathway to death, and therefore hopefully in the pathway to worsening, and therefore you could treat. But you know, we don't have it yet. I do think that machine learning approaches may help with that. You know, it's just been so complex in the past that I think that will be helpful. You know, it showed that the study on targeting saturation, in which you're able to extract data that you know you wouldn't have thought possible in the past. So I think that's the way I would go about doing it. So it could happen sooner than we think. But then of course, it has to be prospectively tested. So that'll take 5 years just to test it once you have the hypothesis.
So thank you. We should move to the next presentation, which will be given by Professor Michael Pinsky. He's a well-known critical care doctor. He has published more than 400 peer-reviewed manuscripts and 27 textbooks, and mentored over 40 postdoctoral trainees, most of which remain in the academic medicine. So the heart-lung interaction with Michael Pinsky.
Thank you. Welcome. So I'm really pleased to come and give the lecture. I'm also pleased the lecture came up so I can give this talk. I should have titled this, Are Heart-Lung Interactions Still Clinically Relevant? Because most of the work that was done on this years ago, people have said, is it still true? And the answer is yes. My conflicts of interest haven't changed since this morning. What we do know is that cardiovascular insufficiency occurs with initiation and withdrawal of mechanical ventilation. When you're on the ventilator, not much happens. Intubation causes cardiovascular collapse in about 45% of patients who are emergently intubated, and they stay hypotensive for more than 1 hour. The other things that ventilation does is it changes intrathoracic pressure. Increasing intrathoracic pressure with positive pressure breathing must decrease venous return, and PEEP and positive pressure breathing can alter pulmonary vascular resistance, and extubation is a major cardiovascular stress. Risotto et al. Did a study which I can't believe was actually published because it was so obvious that this is what they would find, and we've been showing it for years. And they looked at 29 countries and a whole bunch of patients who had emergent intubation, and they discovered that almost half of them had cardiovascular insufficiency for more than an hour, severe hypoxemia, and cardiac arrest. Also, pre-loading the patient with fluids didn't help, and if you understood heart-lung interactions, you'd understand why. And finally, the one thing that did seem to work is if you didn't give them too heavy a sedation before you intubated them, it helped a bit, but the signal was pretty small. The problem is that intubation mechanical ventilation will decrease cardiac output and oxygen consumption because it decreases the work cost of breathing, so that cardiac output goes down is probably not a bad thing. You can minimize the fall in cardiac output if you allow the patients to have spontaneous breaths. So it is absolutely possible that you can get cardiovascular collapse, but it's due to a lot of things. Number one, you're giving sedation, and so if a person was fighting to stay alive before you intubated them, and you take away that sympathetic tone, they can become hypotensive, vasodilate, etc., and that will decrease venous return and mean arterial pressure. Positive pressure ventilation causes hyperinflation, and as I'll show you, when you put the ambu bag on and you squeeze 3 times to hear a breath, you've already hyperinflated the person and you could kill them, especially if they've got chronic obstructive lung disease. Positive pressure ventilation also increases intrathoracic pressure. So breathing is exercise. The number of studies that have shown that going from CPAP to spontaneous breathing increases oxygen consumption, requires exercise to occur, causes, if you have heart failure, gut ischemia, or other things, are too numerous to count. Amal Jabran showed in patients who had a PA catheter in, and she could measure mixed venous oxygen saturation. If the patients failed to wean, the O2 sat because their cardiac output couldn't meet the metabolic demands. They extracted more oxygen, and the mixed venous O2 fell to less than 50%. If you put a PA catheter in a person and their mixed venous O2 was 50%, you would be very worried that they were in severe shock. And that's what happens with weaning. Exercise is the big fish, and this is a 24-inch trout, and I caught it on a fly, and yes, I did turn it back, catch and release. If weaning is exercise, it can be used as a cardiovascular stress test, and the number of studies that have shown that in patients without coronary disease, you can have acute myocardial injury with elevated enzymes, etc., are too numerous to count. One of my favorite studies was done by Francois Lemaire. Laurent Bouchard was a resident at the time, and the guy that did most of the work was Jean-Louis Thibault. But what they did in this study with COPDers is they had them on the ventilator, they gave them T-tube trial because they thought they could be weaned, and then they failed. And this is an example of one case, and this is a picture that I took because Francois Lemaire, at the end of his abstract presentation of ATS, took the slide out of the carousel and handed it to me and said, Michael, this is your study. So this is the original paper's data. Okay, I took a picture of that. I kept the slide too. What we see here is a patient who's got an esophageal balloon, and the esophageal pressure is about, I guess, 2 or 3, and it's positive because they're lying supine and the pressure of the heart's on the esophagus. And it looks like there's a spontaneous breathing-induced positive pressure, so that's a cyst control. And you can see that the pulmonary occlusion pressure is around 18. What happens with the 5 minutes of spontaneous breathing, you can see the end expiratory esophageal pressure is less. Why? Because the lungs are being held at a larger volume, so the esophageal pressure goes down. That's normal. In exercise, you don't breathe all the way out, you breathe at a higher lung volume. I guess it's because it makes the airway resistance less, but I have no idea. And you can see the massive negative swings in intrathoracic pressure down to minus 25. The pulmonary artery occlusion pressure, which now is actually should be more negatively affected, is risen, and it's now 40. Anything over about 24 is really bad, so 40 is terrible. After 8 minutes, you can see the agonal respirations as shown by the esophageal pressure swings, and the pressure is now up to 50, and I asked Francois at the end, what is that final point right there? And he said, we put the patient back on the ventilator or he would have died. Said in another way, this is not subtle. If you're going to wean a patient, do not leave the room when you put them on the T-tube. You will see almost immediately if they don't make it. Okay. So now let's switch from that and talk about heart-lung interactions. And for this, we're going to have changes in lung volume and changes in intrathoracic pressure. With all forms of breathing, lung volumes start from one value and get higher. But with spontaneous breathing, intrathoracic pressure goes down, whereas with positive pressure breathing, intrathoracic pressure goes up. So the hemodynamic differences between spontaneous and positive pressure are not really due to changes in lung volume per se, they're due to changes in intrathoracic pressure and the energy necessary to produce that change. But let's look at lung volume first, because it's pretty important.
Then
the lung is unique.
Models of subarachnoid hemorrhage, and then most.
Are you here, subarachnoid hemorrhage over here? Yeah. Okay. There are alveolar and extraalveolar vessels. The alveolar vessels are the capillaries, and they're sensing as their outside pressure, alveolar pressure. And the rest of the vessels, the pulmonary arteries, arterioles, pulmonary venules, and veins, sense the pleural pressure as the extrathoracic pressure. And I will remind you that the difference between alveolar and pleural pressure is the transpulmonary pressure, the distending pressure of the lung. So as the lung volume gets bigger, the transpulmonary pressure gets bigger. So if the transpulmonary pressure exceeds a pulmonary artery diastolic pressure at end inspiration, the vessels will spontaneously collapse, decreasing cross-sectional area and increasing pulmonary vascular resistance. And one can look at it this way, that we have pulmonary vascular resistance as a function of lung volume, from residual volume to functional residual capacity, total lung capacity. And you can see that, like many things in life, it's a U-shaped curve. But the cause of the increase in resistance at low volumes and high volumes is different.
Questions to come. I will say that
Okay, as you can see, with the alveoli don't have any vasomotor tone or anything, so the only reason their resistance goes up is because your transpulmonary pressure collapses the alveoli. And that's hyperinflation. All forms of chronic obstructive lung disease, when they go to respiratory failure, are hyperinflated. But look at the other way. If the lung volumes are small, the terminal airways collapse, and by the process of hypoxic pulmonary vasoconstriction, pulmonary vascular resistance goes up. All forms of acute respiratory failure due to ARDS have small lung volumes. So in both cases, COPD and ARDS, the pulmonary vascular resistance is high, but for opposite reasons, ARDS and COPD. Okay. Canada, from Bill Sybil's lab, caused unilateral lung injury in a dog in which they had one lung was injured and the other wasn't, but they both had the same pulmonary artery pressure and right atrial pressure. And in the example in this case of the animal's the injured lung, you can see the pulmonary vascular resistance was high. When they gave 5 and 10 of PEEP, it went down slowly and then went up a bit. If you look at what happened with the normal lung, they switched from left to right in various animals, so it had nothing to do with the side of the lung. It was which one was injured. You can see that the pulmonary vascular resistance is much, much lower. And they gave 5 of PEEP. It got a little bit better, probably a minor degree of hypoxia reversing microatelectasis. You know, that's why we give 5 of PEEP to everybody, right? But as you go more and more PEEP, the pulmonary vascular resistance went up. But look, it doesn't matter if you have acute lung injury or normal lungs. If you hyperinflate them, they all increase their pulmonary vascular resistance. And that was shown by Peter Suter in his original paper looking at optimal PEEP. If instead of looking at the shunt, as you see, as you go up and up on the PEEP from the best PEEP in terms of cardiac output, you can see that the shunt continues to go down. The shunt continues to go down, but maximal oxygen transport's occurring there. I want you to look over at the other side. We talked about dead space. If I'm increasing blood flow and not overinflating the lungs, the dead space goes down. This is forgotten many times, which is why you should measure end-tidal CO2 as part of your titration, because it'll go up. Okay. An interesting study was done by the group of Xavier Monet, in which they gave 10 of PEEP to patients and looked to see if they hyperinflated or recruited lungs. And what they found was that in some of the patients with ARDS, if they gave 10 of PEEPs, there was a slight decrease in pulmonary vascular resistance as there was lung recruitment, and they measured the recruitment. And they saw no difference in right ventricular function. Whereas in the patients who were given the same 10 of PEEP, they had a slightly lesser increase in lung volume, and they were overdistending. And they had an increase in pulmonary vascular resistance, dilation of their right ventricle, and they weren't doing well. So giving the same PEEP to 2 different patients, if it recruits lungs, it's good, but if it overdistends, it's bad. Okay? And when we think about it, the way we breathe out is passive against a resistance and a compliance. We put the volume in normally with a ventilator, we can blow it in as hard as we want, but it comes out passively with a classic time constant. And if the time constant's a function of the resistance times the compliance. So if I have really compliant lungs or got really high resistance, air doesn't come out fast. And that is shown here, and just an example. This is actually Bergman's data summarized in Martin Tobin's textbook. you can see that if you don't have enough time to breathe out, you in 3 breaths will reach a point of hyperinflation. So let's assume you intubate someone, and then the doctor puts his stethoscope on and listens at the lungs. I don't know a single person that won't take that 3-liter bag and go whoosh, so they can hear the lung, and they will look at the other side. Whoosh. 3 breaths like that, and you've already hyperinflated the lungs to the point of cor pulmonale. And if they have COPD, they're hyperinflated and they may die. Okay? And we know that hyperinflation is profoundly common. And Pepe and Marini wrote a paper in which they just demonstrated this occult PEEP. This wasn't even a scientific presentation because according to the editors of the Blue Journal, this was already known. But they just wanted to let it be a clinical commentary. And you can see the COPD was on a ventilator, cardiac output's low, the esophageal pressure measuring hyperinflation was there. All they did was take them off the ventilator, remove. You can see the esophageal pressure falls, the wedge pressure falls, but cardiac output and blood pressure go up. Putting him back on the ventilator, it comes back. Why does this happen? As the lungs hyperinflate, the chest wall goes out, the diaphragm descends, but the heart is trapped in the cardiac fossa and is compressed. This was nicely shown by the group from Lynn Hudson's group in Seattle, in which they measured a person index expiration of 0 and 10 of PEEP.
Thank you very much for.
And as you can see, 10 of PEEP,
The
look at the
is,
small
and
size
rightfully so.
of the volume. I'm seeing language, their information's coming here. Is there some way you can fix that? Okay. See, this is not subtle. Okay. So now let's look at the effects of intrathoracic pressure. To understand that, you have to accept the following hypothesis. The hypothesis is that the heart is in the chest. Do you accept that hypothesis? If the heart is in the chest, it's a pressure chamber inside a pressure chamber, and thus increases and decreases in intrathoracic pressure have to affect the heart independent of its heart itself. It's a pump. So venous return is the easiest one to think of. If we look at the normal ventricular function by Guyton, where he increases right atrial pressure to increase stroke volume, that's a Starling curve. That's for the left ventricle. But as you increase right atrial pressure, you are damned to venous return, and as you decrease right atrial pressure, you have more flow back, and so you can create a venous return curve. And this means that in you and I and our patients, there exists one and only one right atrial pressure and cardiac output that we can have, which is a function of our ventricular function, venous return, and blood volume. Okay? So what happens with positive pressure breathing and spontaneous breathing? When I took an animal model in which I put a flow probe on the pulmonary artery, closed up the pericardium, allowed it to breathe spontaneously, and you can see with pleural pressure falls with spontaneous breathing, there's a slight decrease in CVP, makes right ventricular filling pressure and stroke volume go up. Contrast that to a positive pressure breath that by increasing the lung volume increases pleural pressure, causes CVP to rise, right ventricular filling to go down, and right ventricular stroke volume to go down. Okay? This happens with every breath. And this was published in 1984. Raise your hand if you weren't yet born in 1984. Raise your hand. Okay. So we can comfortably say to you, we knew this before you were born. So the effects of positive pressure are going to decrease venous return. And so how is that going to work? We're going to see, remember, an increase in CVP and a decrease in stroke volume, right? That's what it looks like here. What do we do in the operating room? We give them fluids, and we say, I'm going to give them volume, and I'll get another value, and they'll be happy. But watch, let's extubate them, as Francois Lemaire did. What's going to happen? You're going to markedly increase their volume. That is the reason why we say, in a patient who you're going to extubate, run them dry. Because you know that when you move from positive pressure to spontaneous breathing, intrathoracic blood volume always increases. And in fact, as we showed, if you look at the left ventricular area in a human being using echo, that with positive pressure breathing, after about 2 beats, the left ventricle has less volume as well. And if you have greater and greater tidal volumes from 5 to 10 to 15 to 20, as we showed with Jaime Mosqueda when he was with us from Spain, there's a greater amount of blood leaving the chest on inspiration that returns on exhalation. So increasing intrathoracic pressure decreases venous return, but it doesn't hurt us normally because the diaphragm descends, and if I'm volume resuscitated, the abdominal pressure rise from the diaphragm descend causes an artifactual shift of the venous return curve. So this means that even though we will see some degree of decrease in cardiac output, it's not as bad as in a hypovolemic person. But if you have a patient coming in trauma, they're bleeding, and you have to put an airway in because you want to defend the airway, you darn well better have IV fluids running, because the next thing you'll be doing is calling a code for no cardiac output. So now let's look at left ventricular ejection. And that's the transmural pressure. And this is a picture I drew years ago, 1979, literally on a napkin, and we made it into one of the figures in our paper in the New England Journal. If you assume that a heart is beating, and it's the box is the thorax, the crescent is the heart, and the arrow is the aorta out to the extrathoracic body, and let's assume that the arterial pressure is 150. And on the left side, we give a pure alpha agonist, phenylephrine, which you guys should never use, by the way, you should use norepinephrine. But let's assume we did a pure alpha agent, and I get the pressure up to 200. Everyone will agree I've increased afterload from 150 to 200. But watch, if I keep the pressure at 150 and I make the pressure in the chest minus 50, as far as the heart's concerned, that's the exact same increase in intrathoracic pressure. When do I see massive negative swings in intrathoracic pressure? Well, that person who was being a spontaneous breathing trial, a person with upper airway obstruction, an asthmatic. Those are the people who will have that. So decreases in intrathoracic pressure increase left ventricular afterload, and increases improve ventricular function. And if you're in heart failure with the decreased afterload, you may actually see that even though the venous return is going down a bit, the cardiac output goes up. And in fact, we saw that. In this animal model of heart failure with volume overload and using jet ventilation so that the tidal volumes were very small, you can see that we progressively increased the driving pressure to increase intrathoracic pressure, and the intrathoracic vascular measurements of right atrial pulmonary all decreased because we increased intrathoracic pressure. But look, in the heart failure model, stroke volume went up. That's the same way that nitroprusside can increase cardiac output in a heart failure model, but it only goes so far. If I could remove a negative swing in intrathoracic pressure, that's the equivalent of adding it, but I don't have to worry about decreasing venous return. So if I just abolish a negative swing in intrathoracic pressure, I should augment cardiac output. What does is that? Taking away status asthmaticus, upper airway obstruction, or pulmonary edema, CPAP. This is why the treatment for acute cardiogenic pulmonary edema is mask CPAP. And the number of studies that have shown that acute cardiogenic pulmonary edema and obstructive sleep apnea-induced heart failure are easily treated with CPAP to abolish the negative swings in intrathoracic pressure are again too numerous to mount, and this is now the standard of care to treat these things. And you don't give Lasix, you give CPAP. The patient is not hypervolemic. And in fact, the effect only works when you finally stop the negative swings. So in this one example, this patient, it turned out they needed 15, but it'll be different in everybody. And in fact, both short-term and long-term survival of patients with acute cardiogenic pulmonary edema is markedly improved by the use of CPAP. So in summary, failure to wean from mechanical ventilation often represents cardiovascular insufficiency because breathing is exercise. That's the reason why you have no ability to predict weaning success or failure by looking at respiratory mechanics, because at no time do those assess ventricular function. Endotracheal intubation often causes cardiovascular collapse. Hyperinflation from the large breaths can occur in 3 breaths, and it takes a long time to go away. Never intubate a hypovolemic patient unless you've got fluids coming in with it, because they'll die. And the other thing that happens with intubation of a patient in shock is you get pharmacologic loss of sympathetic tone, hyperinflation, and a decrease in venous return. So you get a trifecta of bad things happening. And it's not surprising that you're going to get problems, but you don't treat every patient the same way. Some may need norepinephrine, some may need fluids, most of them will need to not have hyperinflation. And obstructive spontaneous breaths cause pulmonary edema. And with that, I thank you for your attention.
I think we have a time for a couple of questions, maybe.
It's clear as mud.
Is it so frequent to have pulmonary edema in obstructive sleep apnea?
Not a pulmonary edema and obstructive sleep apnea, but they get pulmonary hypertension and right heart failure, and if you give them CPAP, the CPAP only benefits those that have heart failure for just that reason. But we used to put a PA, in 1978, when I was at Stanford, we used to put pulmonary artery catheters into patients in the ICU who were coming in for sleep studies, because there was no such thing as a sleep lab in those days. That was the basis of our research that came out in the New England Journal, where we spontaneously, in volunteers, we made them have negative swings. And we were able to see massive negative swings in pleural pressure associated with increases in transmural pulmonary pressure well up to the levels of pulmonary edema, but they were episodic.
So if there is no other question, we move to...
Thank you.
Oh, there is a question.
Oh, there is. I see. The lady who asked the last question. Good going.
Just quick question. So you said that even though when we intubate, we know that the venous return will decrease, but do not give fluid. It might be bad. So like physiologically, it makes sense that when I intubate, the venous return is going to come down. So I always grab like, have a liter and ask, the nurses to run the fluid, because I know that the patient blood pressure will drop. So would you rather give a fluid or initiate maybe small dose pressor like norepinephrine before you intubate?
Well, the question is, if I'm going to do emergent intubation, I would like to know what was the volume status of the patient prior to intubation. What do I think is happening with their lungs? Do they have chronic obstructive lung disease? Because if they do and they bag them, I don't know a single respiratory therapist is going to do this with a bag. It's a 3-liter bag and they're going to squeeze it. I see it all that. I say, stop, and they look at you, what's wrong? Because they want to make the breath sounds heard. And I think you've heard this, where they said, we intubated them, but then we were difficult to ventilate, right? How many times have you heard that? It's because of hyperinflation. So I can't treat hyperinflation very well with fluids, okay? I have to stop ventilating. I can't treat hyperinflation very well with norepinephrine, but it'll help. So I have to identify what are the risks that this specific is it COPD? If it's ARDS, I'm not as worried about hyperinflation, but I definitely would, in those, be much more worried about vasomotor tone. So what I would do is, if I thought they were, quote, metastable, I would make sure that if I'm going to intubate them, because 50% of them are going to have cardiovascular insufficiency, I'd have norepinephrine ready to go, okay? Would I give phenylephrine? No, because phenylephrine invariably causes cardiac output to go down, okay? Though your blood pressure is up and everyone smiles, perfusion goes down. So I would give norepinephrine, and I would give fluids judiciously, but what I would do immediately as they start to have problems is I would use an echo and look at the heart. Do I have a dilated right ventricle? Do I have a collapsed right ventricle? And that would tell me immediately whether or not I needed to give fluids, inotropes, or stop ventilating as much as I did.
But norepi also a pure vasoconstrictor like phenylephrine, so why would we think phenylephrine?
Norepinephrine, it's also an inotrope, and usually cardiac output does not go down and sometimes goes up, okay? But it's got alpha and beta effects, unlike phenylephrine, which is pure alpha.
Thank you. Okay, now so we go with our final speaker for this session is Mr. Thomas Priano. I hope I'm pronouncing your, okay, good. He's a registered respiratory therapist, educator, and consultant. He's also a lecturer for the Department of Anesthesia, Division of Critical Care at McMaster University. He has spoken at more than 50 conferences, authorized research, editorials, and textbook chapters, and he's the editor of the Center of Excellence in Mechanical Ventilation blog. He is an editorial board member for respiratory care, and he has won several awards and recognitions for his contribution to respiratory care. Welcome, Mr. Thomas.
No.
Okay, I desperately need this lecture because I've been struggling with the opening pressure. So I'm sure I will benefit a lot.
I hope to do it justice with my explanations. Great, thanks. Hopefully it's just the title that changed the font, but the font has changed since it was. Okay, so it's not just me. And to respond to your comment, Dr. Pinsky, I was born in 1984, but they didn't teach that fascinating stuff in the 3rd grade. So I'd like to echo the comments on the hospitality here in Kuwait. This is my first time to the Middle East, and I would absolutely come back in a heartbeat. And thank you so much for inviting me to provide this lecture. So I'm going to talk about airway closure, or airway opening pressure in ARDS, an underestimated phenomenon. These are my disclosures. They have absolutely nothing to do with what I'm going to present today. The objectives will be to describe airway closure, explain why we think it's underestimated, and then describe ways of assessing airway closure for the proper setting of the ventilator. So what is it? Airway closure is the pressure at which the airways may close or collapse. Historically, it's been described in patients with COPD, asthma, and obesity. And more recently, however, it's gained traction and more interest in patients with ARDS, patients post-cardiac arrest, and patients with cardiogenic pulmonary edema. Now, why do we think it's underestimated? Well, the main reason is that most, I would say in routine practice, we're not performing slow flow inflation pressure volume curves at the bedside. Is anybody checking slow flow inflation routinely at the bedside? I didn't think so. Okay. So we're not checking it. And in fact, we have a misinterpretation. Why we think it's misinterpreted, it's underestimated because we're not measuring it, but why we think it's misinterpreted is the classic description of the lower inflection point was the opening pressure of previously collapsed or compressed alveoli. And what they found in this study over 20 years ago, they looked at PEEP levels above the opening or the lower inflection point when they would reduce PEEP by 5 centimeters of water each time there was a derecruitment volume. So each time you lower PEEP, there's an expected loss of end expiratory lung volume. When you lose more than what's expected, it's considered a derecruitment volume. So they found even though we're above the lower inflection point, there's still derecruitment. So clearly the lower inflection point is not simply described as alveoli that are now magically open and remain open. And so also, if you do perform these maneuvers in ARDS patients, you will find many ARDS patients have absolutely no lower inflection point as shown here. And of course, you could argue that you're certain they likely have atelectasis on a PEEP of 0 if they're an ARDS patient. Otherwise, I'm not sure how they got classified as ARDS based on the current definitions. And then in some patients, you may have more gradual inflection here, and then you have, in these patients, a very abrupt inflection point. And you'll notice the red line on the screen, and this is the circuit compliance. So this is a slow flow inflation curve of a completely blocked circuit. And this was first described by Lu Chen and colleagues in 2017, and the title of their paper was essentially the title of my presentation. And what they did that was actually quite clever, they saw this drastic inflection point, and they thought, let's overlap the pressure volume curve of a completely occluded circuit. And you'll notice that up until the pressure of maybe 16 centimeters of water here, you can see that it matches identically the compliance of the circuit. So this implies that up until 16 centimeters of water, nothing from the applied pressure of the ventilator is actually inflating the lung. It's simply inflating the circuit of the ventilator tube. or the ventilator tubing of the ventilator, the circuit. So also what they noticed is they had CT scans performed on many of these patients, and they found that there was no evidence of alveolar collapse, and so this indicated that perhaps the site of the closure was the airways rather than the alveoli because they remained open. And also, there was question whether or not this had to do with a negative end expiratory transpulmonary pressure, and many of the patients at the lowest PEEP level, which was 0 in most of the cases because they were doing these slow flow inflation from 0, was not significantly different between patients with and without airway closure, so it wasn't simply described as a transpulmonary pressure issue. And finally, it also wasn't described simply by saying, oh, this is total PEEP or this is trapped gas from ventilation. In these examples, they have the PEEP low setting is here. This is the total PEEP based on an expiratory pause. And then what they did is they just changed the respiratory rate to allow a much longer expiratory time. And you can see that they essentially removed the total PEEP just by providing more time. But at the same token, there is still airway opening pressure beyond this. So when you do an expiratory pause, it's representing the pressure that is in the lungs at end exhalation, but when you have airway closure, you remove that communication to the alveoli, so it's not truly representing a pressure that actually opens up these distal airways. So what causes it? The exact mechanism remains unclear. There's much speculation, but we don't know exactly. But I think the speculations have some physiological rationale behind them. One is that at AOP, and again, I will interchange the term airway closure and airway opening pressure, because closure is the act of it closing. The airway opening pressure is the pressure required to open it. So AOP may represent the airway pressure required to simply counteract surface tension and clear interbronchial liquid that leads to airway closure. It could be surfactant depletion in ARDS patients that may contribute to this phenomenon. And how common is it? It's in the papers that have measured it routinely. They're finding it in anywhere between 20% and 40% of ARDS patients. So if we're not checking it by doing measurements, which, as you probably anticipated, it's by doing a slow flow inflation curve, we're clearly not recognizing it, but it seems to be more prevalent than we had imagined. So what's the clinical significance? One potential significance would be denitrogenation atelectasis, particularly in patients that you're using high levels of FiO2. When the airways collapse, there's still absorption of the oxygen, which can lead to atelectasis. But probably one of the most important factors, or the two most important factors, one is the erroneous calculation of driving pressure. This is actually extremely important if you're performing research where you rely on the calculation of driving pressure. If you're not assessing airway opening pressure, your driving pressure may be an inaccurate measure. And there's also this potential risk of ventilator-induced lung injury when there's repeated opening and closing of distal airways when PEEP is set below airway opening pressure. I will point out that if your PEEP is set above your airway opening pressure, this is an irrelevant lecture. But unless you're measuring it, you don't know if your PEEP is set above airway opening pressure. So in this example here, this was a nice study done by Domenico Greco and colleagues, published in Anesthesiology. And they do what's called a pressure time curve assessment of airway opening pressure. So rather than a slow flow inflation pressure volume curve, they do a slow flow inflation and assess the pressure time curve. And you can see here they do a long expiratory pause, but first I'll point out the driving pressure. This is plateau minus the set PEEP. You can see in this patient there's a very large driving pressure compared to this person over here, this patient with a driving pressure that appears to be much lower. They do a long expiratory pause. You can see there's an element of total PEEP, some, again, measured by the ventilator. This would be the measurement that would have appeared if they did an expiratory pause normally. And then here you have this slow flow inflation maneuver that occurs, and you see this very clear inflection in the pressure time curve. And if you were to take the point of airway closure where the lungs are actually opening, this is the inflation of the lung. And this is the actual true respiratory system tidal elastance. So very different than what you observe on the ventilator. This is the actual driving pressure. And in fact, this patient's true driving pressure is actually lower than the patient without airway closure. And this study looked at patients that had obesity, and also, so they compared basically patients that exhibited airway closure and those that did not, but they both had similar characteristics, including BMI. And the potential for ventilator-induced lung injury, we have some animal studies that demonstrate airway injury at areas that are not associated with atelectasis. So the question is, was this airway injury a secondary effect of airway closure? Again, this is animal studies, but it's just fueling the theoretical or potential concerns about airway opening pressure and airway closure. So what should we do about it? The current opinion, and I say this because we don't have a randomized trial of how to manage this essentially, but the current opinion is to set PEEP at least at airway opening pressure, but this, again, we think is misinterpreted that it's not the area of recruitment. So although you may set your PEEP at airway opening pressure, the patient may need higher levels of PEEP to actually recruit or to provide some benefit if the patient is recruitable. However, I feel clinically it should be reassessed routinely. So edema may resolve, and the changes in patient position may also affect this. I've clinically had patients that I've measured airway closure in a post-cardiac arrest patient, and the airway opening pressure was 16 centimeters of water. When I adjusted PEEP to that level, there was absolutely no impact on hemodynamics. The driving pressure was now accurately measured. However, when I checked 4 hours later, because in a post-cardiac arrest patient, you can imagine how quickly their fluid status is changing. Within 4 hours, the airway opening pressure was 12, and by the end of my shift, it was now down to, it was either 8 or 10. So significant drop. This is very quickly resolving in some patients. And in this paper, this was sort of a case report that was published in Chest in 2023, where they describe also this additional phenomenon of this uncorking effect, which they think is because of large airway involvement. But in these patients, this is essentially on ICU admission, and you can see a large amount of airway closure. The true driving pressure is here. This is the apparent driving pressure. But look at the next day. The next day, there was essentially no airway opening pressure or no airway closure in this patient. So it's very important that you don't just assess this once, adjust your PEEP, and forget about it. You should reassess. And again, just another example, 24 hours later in this patient, again, no evidence of airway opening pressure. So this is also a nice image that was submitted to the Blue Journal by Lorenzo Del Sorbo and colleagues. This is a patient with ECMO. Again, you can see the slight uncorking effect here. We have a higher airway opening pressure here, and then it drops down. But you can see a very clear inflection here in this pressure time curve. Now, what's important to note, this doesn't have the circuit compliance there. I don't have that nice red line that we had in the other papers. But if you were to take the change in pressure here from PEEP, the starting level, to this opening pressure, and divide it by the amount of volume that entered the lung, you would essentially get the circuit compliance. And I'll show you an example of that in a moment. They also published this paper last year, Lorenzo Del Sorbo and colleagues again, showing that airway opening pressure was impacted by position. So when they placed these patients with very high airway opening pressure of 21 in the prone positioning, the airway opening pressure dropped to 13 centimeters of water. And then when they resupinated the patient, it increased back up again to 17 centimeters of water. So again, any major changes to patient position or their fluid status, we really should reassess, particularly if you're adjusting PEEP based on this airway opening pressure. So how do we measure it? So if you don't have a slow flow inflation maneuver on your ventilator, you can actually use volume assist control to do this by simply adjusting the settings. I'm going to show you a video next where using essentially, this patient is in pressure control, and I will switch modes to ventilators. Many ventilators allow you to switch back to your previous settings with the touch of a button. So I'll use a mode that I would never use clinically on an ARDS patient, which is SIMV. I'll switch to SIMV volume control just to use the volume control settings, and then as soon as I'm done the maneuver, I switch back. And then I'll discuss a novel method for assessing dynamic pressure time curve during volume assist control, or something they call the conductive pressure. So first, I just want to show you a comparison before I show you the video. This is a patient with no airway closure on the left. You can see this is the slow flow inflation pressure volume curve. They're inflating the lungs with 5 liters per minute of flow. This is in order to remove the resistive pressure component. And you can see this is the pressure time curve where there's no inflection. Over here, we have this progressive inflection, and I'll talk about what this means in a moment. And there's the pressure time curve. You see the same progressive deflection here, and again, this is pressure time versus pressure and volume. And then over here you have an abrupt change, and you can see this very clear inflection in the pressure time curve. So if you don't have a fancy maneuver, you just use the ventilator mode, and this is how you do it. Oh, not yet. Okay. I'm going to quickly describe this first, I realize. We have EIT studies now that have demonstrated, this is very fresh in Press Critical Care 2025, this progressive change in airway opening pressure, when they looked at electrical impedance tomography to look at regional airway opening pressures, they found that when your inflection is quite mild or progressive, it basically implies that what it's showing you here is the lowest airway opening pressure within the lungs, but there are higher airway opening pressures in the dorsal lung regions. And the difference between the two is significant. When you see a very abrupt change, the airway opening pressures across all regions in the lung are very, very similar. So it's almost like a complete airway closure. So that's why you have such an abrupt change. Now, to measure this on the ventilator, any ventilator that has a volume assist control mode, again, constant flow is very important. You're going to set the flow at 5 liters per minute. Now, if your ventilator is not set up, some ventilators by default, you have to use I-time, like the Servo U ventilator or Servo I that I'll show you in a moment. You have to set I-time or you have to set I-E ratio. It depends what your ventilator is set up. You would set a frequency of 5 on the ventilator, a PEEP of 5, and then if you have flow, great, set flow. Otherwise, you can set and you have to set your tidal volume. You can set it around 300. That should be safe for most patients. 3.7 of an I-time and 1.22. These are just quick references if you want to quickly do it without messing around with how should I set it, what should I do? So here I'm going to switch to SIMV because I would not use that clinically on this patient, and I want to be able to switch back quickly and not have to adjust my settings after. My rate is set to 5. My tidal volume is set to 300. I-time to 3.7. You'll see it gives me a flow of 5 liters per minute. And all I'm doing is a slow flow inflation of the lung, and finally set my PEEP at 5. You could set it at 0, but I clinically wouldn't use one below 5, so I start at 5. You'll have an expiratory phase. When the next breath is delivered, I'm going to hit the record button on this ventilator. Other ventilators, you can just freeze the waveform as long as you can manipulate your cursor. On the Servo I, you have to record it, so I've pressed save. You can see a very clear inflection. I'm now immediately going back to my previous settings so that I'm not messing around with my patient. Now they're back on clinical settings. That's how long it took me to do the measurement. Now I'm simply waiting for the ventilator to finish its recording. Now I'm going to go in to review the recording, and I'm going to move my cursor along to the inflection point, and that is the airway opening pressure. So in this example here, the airway opening pressure that we decided on when I played around with the cursor was 16 centimeters of water. Now, again, I mentioned before that how do you know if this is a complete airway closure? If I take 16 minus 5, that's the airway opening pressure minus my starting PEEP, it's 11 centimeters of water, and the tidal volume measured where I put my cursor is 29 mils. 29 divided by 11 is 2.6 mils per centimeter of water. The average compliance of a ventilator circuit is less than or equal to 3.5 mils per centimeter of water. So this is complete airway closure. And finally, there's a novel method that it was recently described in a paper published in 2023 in Critical Care, looking at they call this the conductive pressure. So using volume assist control with a flow of 60 liters per minute and an inspiratory pause of 0.3 seconds, they looked at the resistive pressure can be demonstrated by peak minus plateau. And the conductive pressure here, if it's the same delta pressure here as it is here, then you do not have airway opening pressure or airway closure. In this example here, the resistive pressure is less than the conductive pressure, and when you subtract these two pressures and add them to PEEP, you end up with airway opening pressure. And it actually had quite, I would say, excellent sensitivity and specificity for identifying airway opening pressure. And this is just a clinical example in their physiological bench model, which was done in teal cadavers, which are a soft fix embalming method, which the cadavers retain elastic properties, elastic tissue properties. You can see you have an airway opening pressure of 10 when doing the classic pressure time curve that I just demonstrated on the ventilator video. And here they have the conductive pressure of 24, the resistive pressure of 14. When you subtract those two pressures, you end up with 10 centimeters of water. And when you add that to the starting PEEP, which in this example is 0, you have AOP of 10. And over here, we have an example of the resistive pressure is equal to the conductive pressure after they increase the PEEP to 10, because there's no longer airway opening pressure. They've set PEEP at 10, and the airway opening pressure is gone. So in summary, airway closure is likely more common than we expect because we're simply not measuring pressure volume curves at the bedside routinely. It is not explained simply as atelectasis or low end expiratory transpulmonary pressure. When PEEP is set below airway opening pressure, driving pressure becomes inaccurate. So as an example, there's a large RCT, the DRIVE RCT, which is part of the platform trial. They are requiring clinicians to do measurements of airway opening pressure to ensure that because they're targeting driving pressure in this study, that the driving pressure measurements are accurate. So when PEEP is below AOP, it's inaccurate, but we need to address that. Ventilating below AOP may contribute to further lung injury. Again, we have animal data suggesting that some airway injury could be, airway opening pressure or airway closure could be a facilitating factor for that. Checking for airway closure and determining AOP can be done easily at the bedside, in my opinion, and setting PEEP at AOP should be reassessed routinely. And with that, I'll take some questions.
Okay, thank you very much. This was very interesting.
Since I'm the last,
sure
I can
you have a
stand
lot
up here
of
if we have any questions.
But we are really sorry because we are late in time, so immediately we'll start the next session.
You can follow me out if anyone has
Yeah.
questions. I won't go too far. I'll go outside the door.
Actually, I am a big fan of your blog.
Yes, so the
Yeah.
calculator, it's gone off the screen, but the calculator link was on the screen and the blog
Yeah.
was there as well.
Yeah,
but-
thank
okay,
you.
Thank you.